it's at the point time of the hour, time to get started. Glad to have all of you with us this week. And as we go through our companion material here for neuroscience, and we'll be spending this week primarily on two of the most critical areas of neuroscience for clinical diagnosis, and that is spinal cord and, of course, brainstem. And that will actually involve most of our activity for the week. And these are two critical areas because when you think of neurology, you think of good, solid neuroanatomy, neuroscience. And these two areas, spinal cord and brainstem, organize themselves very nicely in order to give you a nice clinical picture of signs and symptoms relative to making diagnostic decisions about where lesions are and localizing lesions. Where's the neurological disruption? So we hope this week that we'll be looking at these two areas from a clinical perspective and give you some application as you proceed in your medical education. Here on the screen, you can see my information. There is the email address. I encourage you to write it down. I'll have it up there several times during the week. And you can use that email address for any information you would like to ask me, or you have questions before, after class, to be sure and jump in on that email. I see it very frequently. You'll notice I'm from the Memphis, Tennessee area, University of Tennessee Health Science Center, which is in Memphis, Tennessee. So again, glad to have all you with us, and I hope that you will enjoy the week, and I hope we'll gain you some different, maybe new look at neurology as it relates to your clinical development. Now, to get started, we're going to start off here for the first couple of days with spinal cord and dealing with elements of spinal cord. Including a brief introduction here to spinal nerves, the peripheral nervous system. Most of our discussion will be with the spinal cord itself, but we need to introduce and just remind you some of the basic information relative to this component of the peripheral nervous system, the spinal nerve systems. And as you well remember in your previous studies, that when the spinal cord develops, it's going to develop here in a series of segments. And you know what the segmentations of the cord are. You know very nicely that in the development of the cord, there are 8 cervical, there are 12 thoracic, 5 lumbar, 5 sacral, and maybe 1 or 2 coccygeal segments, the coccygeal segments not being that significant. And so from each of these cord segments, you're certainly aware that we derive bilaterally these spinal nerve systems. So the spinal nerves themselves are named, of course, accordingly to the segments of origin from the cord. And of course, notice there are going to be 8 cervical spinal nerves, C1 to C8. Notice these are mostly providing innervation for upper limb and upper trunk. And then we have 12 thoracic spinal nerve systems coming off the 12 thoracic cord segments. And these are going to be supplying areas of trunk. And then the lumbosacral, L1 to 5 and S1 to S5, that lumbosacral, a large network of spinal nerve systems there is the main blood supply to lower limbs, some of the lower abdomen and lower pelvic regions. So we're going to end up there with a series of 31 spinal nerves. But as you well know also, these spinal nerves are repeating patterns of each other. So you do not have to identify and talk about each one of the spinal nerves individually. We can talk about kind of a generic typical spinal nerve, and that's what we want to look at here at the beginning. So let's just review now. And these are from your companion notes, these notes that I'll be using this week, so you have access to these. Notice that what we're going to look at in this image is, again, the distribution and some of the neuronal components of a typical spinal nerve system. And what we have here, of course, is a cross-section of spinal cord. This is central nervous system. That's where we'll begin in a few minutes. But what we want to note at the moment is this peripheral nervous system, some of the information that's critical here for the spinal nerves. Now, notice that where the central nervous system and the peripheral nervous system will junction is where these two roots join the surface of the cord. So there's a dorsal root attaching to the dorsal surface of the cord, and of course, a ventral root attaching to the ventral surface of the cord. So let's look at these two roots. They are the beginnings of the peripheral nervous system. And let's give some physiological and functional structure to them. Now, remember the dorsal root, and there's a typo on your notes I have corrected here, so you can make that change. Notice the dorsal root on its way into the cord is a sensory highway coming into the spinal cord. Notice the dorsal root is a sensory highway coming into the cord. And what this sensory highway is bringing into the cord is all of the peripheral sensory information collected by the spinal nerve systems. And you remember out here in the periphery, here in this blue box, you remember in skin and muscle, there's a network of receptors that are functional in receiving this sensory information. From skin, you've got touch and vibration, 2-point discrimination, temperature, pain. From muscles, you have inputs of muscle spindles, Golgi tendons, giving us sense of proprioception or where your body is. So all of these receptors out here in the periphery are sending their information, and notice the sensory input from these receptors are making their way through the dorsal root. So the dorsal root is a sensory highway bringing all of the sensory information from the peripheral orientation. Now, you also remember that on all of the dorsal roots, there's this little bump enlargement, which is called the dorsal root ganglion. And you want to now identify and remind yourself the neuron who lives there is the unipolar. You can call it pseudo-unipolar, unipolar. And you remember this unipolar neuron is a sensory neuron. And notice its cell body, the circle there of this neuron, is within that dorsal root ganglion. Now, these unipolar neurons are responsible for bringing in that sensory modality. So notice they have a peripheral process, these blue lines that go out through different parts of the peripheral nervous system. And it's the peripheral process that hooks up with these receptors, and there's a transduction of that information. And so this blue line, this peripheral process, brings the sensory information onto the dorsal root. Now notice from the dorsal root ganglion into the cord, this blue part of the unipolar neuron is the central process, and it's actually the central process that makes up all the dorsal roots. So when you think of a dorsal root of a spinal nerve, you think of sensory, you think of unipolar neurons, and you remember this axon that makes up axon-like neuron here that makes up the dorsal roots are the central processes of these unipolar neurons. Now, the number is not important for exam purposes, but you may remember that in kind of a typical dorsal root, there are somewhere around up to 40 to 50,000 of these unipolar neurons that are housed in this dorsal root. So when you think of the dorsal root, that's many of these central processes that makes it up. Another thing you may remember, we'll mention briefly a few pages over, is that these unipolar neurons, sensory neurons, are classified by function, by size, by diameter. So there's an alphabetical classification, there's a numerical classification. But keep in mind, you don't have to delve into that very deeply. That again is not a critical mass for exam purposes, but we'll mention a few of these critical types of unipolar neurons, and they are specialized. There's one for hot, for cold, for touch, vibration. So there are very specialization that goes on within this dorsal root system. So again, the dorsal root is your sensory highway, bringing all of that sensory modalities that you test in a basic neurological exam comes in through the dorsal root. Now, the central process will enter the spinal cord, obviously, and we'll pick that up later on because these central processes can do one of several things when they go centrally. So remember, the dorsal root is again, like the ventral root, the beginning of peripheral. Now let's examine the ventral root. Now notice the ventral root has these red axons in it, red neurons showing as an example. Now notice in contrast, the ventral root is a motor system. It is bringing from the spinal cord all of the motor outflow from that spinal cord segment to the peripheral system. Now you might notice here in the diagram, there are two types of motor systems that are coming via the ventral root out of the cord. These are somatic motor or visceral motor. Visceral motor, part of the autonomic nervous system, which is dealing with our internal homeostasis. And of course, somatic motor are the special types of motor neurons that at conscious levels, for the most part, are innervating the skeletal muscles. And you remember these somatic motor neurons, the big ones for us, there's going to be two classifications of motor neurons called lower motor neurons. So remember, what makes up the ventral root are the axons of these somatic lower motor neurons. Now remember, there are two types of these lower motor neurons, alpha and gamma, coming out that ventral root. The red line shown there is the alpha. That's the more critical one. That's the one you want to remember. That's the one we'll be talking about pretty much for the week. But the alpha and the gamma are the two lower motor neurons. Now, the reason there are two of them, you might remember that anytime you contract a muscle, notice that the contraction of that skeletal muscle can occur under two mechanisms. You know this. One, I can cortically decide I want to bend this elbow. That's a conscious volitional movement. So you can have a volitional conscious movement of skeletal muscle contraction, or I can come to your office and say, Doc, I don't know how to describe my right limb, but it doesn't work right. It's weak. It's not, I don't have the control I did have. And so one of the tools you're going to use to examine that limb or do some deep tendon reflex testing. So you would take your mallet and tap the biceps, the triceps, different reflex points on the limb, and see if you can get a motor jerk. So notice that biceps muscle can contract under reflex mechanisms or under volitional control from the cortex. So again, there are two mechanisms. Now the alpha, again, is the headline here. The alpha is the lower motor neuron that's utilized in both mechanisms, whether it's volitional or whether it's reflex mechanism. So the alpha is active in both of those. And so that's one of the reasons the alpha would be one of our main topics. And then the gamma system we'll say very little about. That's a behind the scene function. This is operating mostly on the reflex side of innervation of skeletal muscles. And the gamma is a very important reflex mechanism for muscle tone control. And again, we won't get into that system to any detail. But notice both of these lower motor neurons innervate skeletal muscle. Now, there are two types of terms used here, extrafacial, intrafacial. Extrafacial is just fancy name just for the muscle itself, say the biceps or the quadriceps. And so the actual muscle itself, the extrafacial innervation to it, that's involved in the volitional movement of that muscle, that's the alpha system. And the gamma goes to an interesting little few strips of skeletal muscle fibers that are within another receptor type system, the muscle spindle, we'll talk a little bit about. And muscle spindles have within them 5 to 10 muscle fibers, skeletal muscle fibers. And it's those skeletal muscles that the gamma system innervates. And that is really there to help regulate the sensitivity of the muscle spindle so that you have a very nice tone control within the motor systems. So again, notice the coming out, all 31 ventral roots, we have these two lower motor neurons. Now, of one thing important to note, all, and that's ALL, all of these motor neurons coming out the ventral roots have their cell bodies somewhere in spinal cord gray. And you'll notice these alpha and gamma, as indicated by the red line, these cell bodies, the origin of these neurons is in the ventral gray, ventral horn of the gray matter. So again, you're going to have alpha and gamma coming out. Now, the alpha is more predominant, probably up to 2/3 to 3/4 of all the lower motor neurons are alpha, and a smaller number, 1/3 or so, will be gamma. Now, in addition to those two motor neurons coming out all ventral roots, notice we have a visceral motor outflow from the spinal cord as well, and this is going to be relative to autonomic nervous system, which is not our full topic for this discussion. And in your companion notes, there's a whole chapter on autonomics. It may be well for you to review that and get a broader picture. But you might remember that in the visceral motor side of autonomics, we have coming out of the cord gray another outflow. They're not indicated in this diagram, but there will be another network of axons coming out. And these will be preganglionics of either the sympathetic or the parasympathetic system. Now, again, if you review the autonomics in detail, you might remember that the entire preganglionic origin of the sympathetic nervous system is from these 14 cord segments, T1 to L2. So the large central part of your spinal cord is comprising what we refer to as the beginnings of this preganglionic beginnings of the sympathetic nervous system. So again, notice, say this spinal cord segment here, if this was any one of the 12 thoracic ones, so you'd have 12 thoracic ventral roots coming out. So those 12 thoracic ventral roots would have alpha and gamma, and they would have also preganglionic sympathetics in that ventral root. And then notice also out of the cord, we have some neurons. These are preganglionics again, but of the parasympathetics. And notice they come out of a different cord segmentation, S2, 3, and 4. And so when you think about S2, 3, and 4, let's say this section here was either sacral 2, 3, or 4, you'd have alpha and gamma. But for those three ventral roots, you would have also preganglionic parasympathetics. So again, notice the ventral root is the motor highway out of the cord, and the dorsal root is the sensory highway into the cord. Now we know these two roots are separate from each other within the dural sac, the dural covering, and we know the dura condenses then here at this oval structure. This is the intervertebral foramen, and that's where the two roots form now the spinal nerve. And the spinal nerve is just a few millimeters long. It's very short, doesn't have a great length to it. And although there have been volumes of books and papers galore written about spinal nerve, it's a very small little segment, because once the combined spinal nerve leaves the vertebral column, it divides into its two main distal branches, which are the continuation of the spinal nerve. And these are dorsal or ventral rami. Now, notice when you talk about dorsal and ventral rami, just notice these are dedicated to different parts of your body. So again, you would not be surprised, the dorsal ramus is going to be dedicated to the back, to the dorsum, just to that area that you could refer to as dorsum or back. And so this is going to be carrying innervation to and from the back. And again, notice then the ventral rami, which are the big ones. These are the ones you will put a little more attention to. The ventral ramus is the main workhorse of the spinal cord, of the spinal nerve, simply because the ventral ramus is going to supply the body wall anterior and lateral. But the big story about ventral rami, notice that they also supply the limbs. So dorsal rami are going to supply just the back, sensory from the skin of the back. So if you touch my dorsum, my skin, with warm or cold, and I perceive that, that is routing through the dorsal ramus via the dorsal root. And again, the ventral ramus is anterior and lateral, but limb. So you remember the ventral root has a lot more distribution to it, and that's why it's much larger, although the artwork doesn't show the magnitude and difference of size. And so it's much larger. And one of the major reasons there's more fibers there is that it's providing limb innervation. So remember, dorsal rami never innervate limbs. That's always the job of ventral rami. And you remember it's the ventral rami that's going to form the classic plexuses like brachial plexus, lumbosacral, for the innervation of the two limbs. So when you think of a spinal nerve system, a peripheral nervous system, those are the concepts. So just review that and just make sure you have an understanding of what is happening when we say peripheral nervous system and spinal nerve system. That's what's going on. It repeats itself 31 times, so it's a repeating pattern of distribution. So that's kind of foundational there. Okay. Now I want to go next to another kind of sidetrack for a moment, and that is to look at a piece of the autonomic nervous system that's related to spinal cord and brainstem. And of course, that's going to be related to the distributions of sympathetics to the head. And we know, and here's an illustration for that, is also from your chapter on autonomic nervous system. And we know that when you're dealing with the autonomic nervous system, we're not even going to get close to capturing any critical, broad information here. But as you might remember, when you deal with the autonomics, you're dealing with sympathetics and parasympathetics. And on the sympathetic side of the world, let's just remind yourself of a few key points that are going to be directly related to the brainstem and spinal cord. Now, what you might remember, and one of the essential things to remember, is that all of the sympathetic system originates between T1 and L2, those two bar lines there. So notice there are 14 segments of the cord that give rise to the preganglionics that will distribute throughout the body as sympathetic innervation. Now you'll notice that these preganglionics here are going to be indicated by these red circles. These are just schematic representations of these preganglionic cell bodies that are in these segmentations of the cord. And what we're talking about here is just one specific innervation, and that's to the head. That's where we're heading in our discussion. And you remember, when you talk about sympathetic or parasympathetic innervation, you remember it's a complex story, but it's a very simple innervation. It only innervates three tissues: smooth muscle, cardiac muscle, and glands. And that's all it does throughout the body. And so in the head, notice the three main targets of the sympathetic system are these. There are two smooth muscles and then the sweat glands in the skin of the face. So sympathetics obviously are very important, as you well know, in dilatation, dilating the pupil. And you do a flashlight test and you're testing the pupil air constriction and so forth. So remember, dilating the pupil is a sympathetic function. And again, if you go out into a nighttime or dim lit room, your pupils are going to open up to allow more light in. That's a sympathetic response. The other thing, there's a smooth muscle in your upper eyelid called the tarsal muscle. And this is the muscle that keeps your eyelids elevated during the daytime once you have raised them volitionally with a skeletal muscle. So remember, in your eyelid, there's a skeletal and a smooth muscle. The skeletal muscle innervated by oculomotor, what you elevate your eyelids when you volitionally open your eyes. So you climb out of the bed in the morning and try to get your eyes open. That's a volitional oculomotor skeletal muscle function. But once the eyelids are elevated, you don't have to think consciously all day long, got to keep my eyes open. That smooth muscle sympathetic tone kicks in and keeps them elevated. And then, of course, there are sweat glands in your face. So when you think of the sympathetic innervation to the head, those are your target components. Now, notice here, what you want to note about this head innervation is that the preganglionics here are coming from primarily out of the T1 segment of the cord. So that's a very important cord segmental level in terms of sympathetic outflow to the head. So if you look over here in this diagram, so here's T1 and here are your preganglionics. So notice the preganglionics here are going to come out the T1 spinal nerve. It's going to come out the T1 spinal nerve, get onto the sympathetic chain on their route going peripherally. Now remember the sympathetic chain, which is indicated there parallel to the cord. You remember that's just a network of sympathetic ganglia hooked together by fibers that streams along the body trunk. And what the sympathetic chain is actually doing is receiving all of these preganglionics from those 14 cord segments. So again, notice all these preganglionics coming out and entering the sympathetic chain. Now, there's more to that story than that, and we would cover that if we were covering autonomics in a little more detail. But notice from T1, this is the primary origin of sympathetics to the head. Notice these are the ones that enter the sympathetic chain, and they just elevate themselves up through the chain in the neck. There's a cervical part of this chain. And notice these preganglionic axons go without interruption up to the superior cervical ganglion, which is the most cranial of the ganglia. And there you have a synapse. And the synapse there, of course, are to the postganglionics. And again, notice the postganglionics are indicated there by blue. These fibers leave the chain and then make their way into the head. And of course, leaving the chain, they have to find another mechanism to get to the head. And of course, that is kind of a hitchhike on the vascular system. So notice these postganglionics will wrap themselves around the carotids, internal, external, and their branches. And these postganglionics become perivascular plexus. And so that's why when you have arterial damage in the head, you're not only interrupting blood supply, but there's potential of interrupting postganglionic sympathetics. So again, remember the postganglionics make their way from the upper neck and distribute into the cranium and the head and the face via the vascular branches of carotid systems. And these postganglionics are the ones that innervate this network of smooth muscles and glands. So notice in the peripheral distribution for this pathway to the head, there's a preganglionic and a postganglionic. Preganglionics are where? T1 gray matter. Postganglionic cell bodies are in the superior cervical chain ganglia. Now, keep in mind, that's not the whole story of this autonomic innervation. Keep in mind, these neurons here, these preganglionic neurons sitting there in the T1 gray matter, they don't have any intrinsic information, whether you need to sweat on the face, the eyelids need to be lifted, and so forth, the pupils dilated. And you remember what is the visceral control center of all of that is our famous hypothalamus sitting up here in the diencephalon. And the diencephalon, the hypothalamus, has a network of nuclei in it, and there's two nuclei, right and left, it's bilateral, that in the posterior region. And again, if we were talking hypothalamus, we would discuss that a little bit. But notice out of these areas nuclei of the hypothalamus, we form a descending fiber tract, heavily myelinated, fairly fast firing tract that descends out of the hypothalamus. Notice it descends all the way through the brainstem, so it's going to be important to us later on in the week. And then it's going to continue into the spinal cord, as you see here. And what happens beginning here at T1, those peel off and drive the preganglionics. So what is driving the preganglionics is this descending hypothalamic tract. So this is a very important term for you. So remember that term, descending hypothalamic tract. So anytime that is damaged in brainstem or spinal cord, and notice as long as you're above T1, you're going to have a Horner syndrome. So you may damage it in the brainstem. You may damage it anywhere between C1 and T1 in the cord. So that could be a central lesion of descending that gives you Horner's. But again, you also can damage peripherally. You could damage the preganglionics. Most commonly damaged is in the sympathetic chain, tumors, metastatic disease, Pancoast tumors, anything that could compress on that sympathetic chain could damage the preganglionics. And then if you have vascular lesions in the carotid system, you could also damage the postganglionic. So notice there are three different areas where you can damage this circuitry and result in Horner syndrome. Now you remember Horner syndrome, if you look at the top of these notes now, you remember what the clinical presentation is. You're going to have that drooping eyelid. You can't keep it elevated. You're going to have a dry face and hydrosis. You're going to have a constricted myotic pupil. Those are all markers of Horner syndrome. Now remember this as a neurological rule. Remember, Horner's always will present ipsilateral. So again, back to our diagram, if you damage the left side of the cord, the left sympathetic chain, the left carotid system, you're going to have a left eye, left face Horner syndrome. So remember, it presents itself ipsilateral. So to quickly review, and this is important because it will come back again in the rest of the week. So remember, to get these targets innervated, it's a 3-neuron sequence. The first neuron is hypothalamus. The second neuron is T1, and the third neuron is in the superior cervical ganglion. So again, neuron 1 of this 3-neuron begins in the hypothalamus. Neuron 2 begins here with the preganglionics in T1, and neuron number 3 is the postganglionics there in the chain. So again, I just wanted to get that brief overview to you so that you'll have a concept of what we will say many times in the following days about Horner lesions in cord or brainstem. So our lesions in the next several days are going to be central lesions. So anytime you damage T1 and above, there's a potential of Horner's. Now notice if the exam gives you a lesion at T5, that's no Horner's. All of that loop circuitry has completed. So any lesion below T1, T2 of the cord, do not expect a Horner event to be part of the distractors in an exam question, for instance. So again, just make sure you understand that. So those are two introductions to the big topic of today and tomorrow, and that's spinal cord. So now we are ready to go central. We're ready to go internal to the spinal cord and talk about the dynamics there. And remember, solid neurology depends on solid neuroanatomy. And so there couldn't be a better connection between clinical area and neuroscience than in the area of the spinal cord and, of course, brainstem. So again, good solid information here will give you a much better clinical skill as you start dealing with your patient-oriented and clinical applications. All right, now when you get to the spinal cord itself, it's the simplest of all the areas of central nervous system. And simplest meaning it's only divided into two layers, two mantles, they're called. There's an external layer, which of course is white matter. Then there's an internal, that H shaped darker area, the gray matter. And of course, we know white matter, gray matter, that's the classic subdivisions of tissues within the central nervous system throughout. Gray matter usually refers to the fact you've got a concentration of neuronal cell bodies, a lot of cell bodies, cell structure. And white matter means you got fibers running somewhere. And so again, here in the cord is divided into those two classic types of divisions. So let's look at these and describe basically what they are. And what we're going to give here on this page are the two most important clinical points that you will use for diagnostic localization of lesions. So we want to stress that as we get there in a minute. Now, again, let's notice that in the white matter, let's look at this first. White matter is divided into different regions of this outer perimeter. And so there's funiculi, funiculus single is the term given. Funiculus is a Latin word for rope. And you'll see in just a moment, it's a very nice term because what's in the funiculi, what's in white matter, are these ropes going up and down the spinal cord that we call long tracts. So there is a dorsal area, there's a dorsal, and there's an anterior, and there's a lateral. Now, of these areas of white matter, most of your clinical significance goes to posterior and lateral. That's where most of the critical systems are in terms of these fibers traversing through the cord. The anterior does have tracts in them, but they are not headline tracts. They're the ones that are kind of behind the scenes dealing with a lot of reflex systems. So again, what's in white matter are these long tracts. Now let's just draw one in. You could just put a big red dot there, and that would represent schematically a long tract within that white matter. Now let's give this cord segment some dynamics. Let's give it a level. Let's say it's T4, the fourth thoracic cord, and this is the left side, and this is the right side of the cord. So let's have some dynamics there. Now notice these tracks that are running up and down this white matter. Remember, some of them are descending tracks, and you remember they are motor in system. These are the ones involved in innervating skeletal muscles. So there are descending motor systems there, and some of them are ascending, going up the spinal cord, and of course those are involved in sensory functions. So when you think of a long tract, let's just take that red dot and expand it. So remember, these long tracts are running all the way, the major ones will run up and down all 31 segments of the spinal cord. So these tracts are just ropes, if you want to refer to them that way. They are bundles of heavily myelinated fibers. And again, notice that they're heavily myelinated, as it says here in your notes. And there are some glial cells. Now, if you think about the glial cell that's there, remember these are primarily oligodendrocytes, because remember that's the primary support glial cell that's going to be myelinating central axons. So the primary glial cell in white matter are these oligodendrocytes. And that would be obvious since these are heavily myelinated axon bundles here. Now, what is important about this concept that these are vertically running, whether they are going up or going down, they're vertically running. So now let's think of a real neat strategy rule that you can use from here forever to predict the clinical presentation of a lesion of a long tract. So let's say now at this exam question or patient, here the pathology here is on the left side at T4. So we're going to have a lesion of some sort right here. at T4 in the white matter. So this is a white matter lesion on the left side at T4. So what's going to happen to all the functions of these long tracts? And you'll notice the critical part of that story is here. This is most important. This is your clinical application here. So when you damage a long tract at a certain level on left or right side, notice the key word in a long tract lesion, you lose the function of that tract below the lesion. Now the key word is below. Now let me illustrate that with you. I've got a string here. And if you'll kind of take this hand up here is the foramen magnum, and you can imagine the spinal cord is vertical here, and I'm holding a cord. And this cord would represent a tract within that white matter. So up here at the top of the cord, you've got cervical segments. Here you got thoracic segments in the middle, and then the lower end, sacral, and of course, lumbar. So most of these major tracts will run the entire length of the cord. Now notice I can take a pair of scissors and damage the spinal cord at different levels. Let's say we damage the cord at, say, in the lower lumbar sacral region. Now notice what happens when I cut the string, I think. Notice what happens. That part of the string below the scissors, below the lesion, fell off. So notice you lose the function of that long tract below the lesion. Or you can have it up here higher in the thoracic region. And notice you lose that tract below there. Or if you had a very high lesion of the cord, say up here in the cervical, you would lose all of the tract below the lesion. So notice the key word here is below the lesion, and that's very important. So remember, when you talk about long tract lesions in the cord, they're below, but it also goes on to say they can be below, contra, or ipsilateral. Now, you know those two terms. They're two terms that describes and compares the side of the nervous system where the lesion is to the side of the body where the presentation of that deficit will show. And so some of these long tracts, let's say, again, we damaged it here at T4, so we've got a damage here at T4. We've lost everything below. We know that. That's the cardinal rule. It's not broken. But sometimes they're below and affect the same size. So this would be the left side of the body. That would be a below an ipsilateral lesion, obviously. Ipsilateral means the same side. So if you damage certain tracts, they're going to be below in ipsilateral events. But other tracts are going to be below and affect contralateral, which of course in this case is the right side. So again, they're all below, but you got to classify below ipsi, below contra. And what determines that is which tract you're talking about. And you'll see that as we move forward. So the key word about long tracts here is that the lesion is below ipsi or contra. That's very, very important. So remember that. So repeat that 5 times for the rest of the evening. And make sure you just don't lose that simple. It's easy, and it's so easy you'll stumble over it. And so anytime you see an exam question and you know you have a cord lesion at a certain level and it's in the white matter, below that lesion is where that motor or sensory function is lost. And again, it's below ipsi or contra. All right, now let's compare that for the second strategy rule here. What about gray matter lesions? Now, again, notice gray matter is divided into some terms. These are just conveniently called horns. So you have a dorsal horn, you have a middle intermediate horn, and you have a ventral horn. Now, the critical ones here are the dorsal and ventral. Those are universal throughout the entire spinal cord. Now, the intermediate ones are going to only be found in certain cord segments, and that's between T1 and L2. If you remember that little cord segmentation from a few moments ago, that represents the cord segmental origin of the sympathetic nervous system. So you're not going to be too surprised that the intermediate gray column is housing preganglionic sympathetics. So that's the reason why that little lateral horn is in some segments. But now notice the dorsal horn and the ventral horns are the universal ones. Now remember what gray matter refers to. These are a collection of nuclei. So there are little lamina of nuclei oriented all throughout the gray matter from dorsal to ventral. And these nuclei are processing either sensory or motor. Now remember, the dorsal horn is processing sensory information, and the ventral horn is processing motor. Neurons there are processing motor. And you know who the lower motor neurons are now. We've already mentioned that a while ago. So who lives in the ventral horn of the cell bodies are the alpha and the gamma neurons. Lower motor neurons come out of that ventral horn. So now you think of a dorsal processing sensory information. You think of a ventral horn, the cell body nuclei groups in there are dealing with motor functions, and the intermediate ones are dealing with the preganglionic origins of sympathetics and a few other things. But one of the headlines there are the preganglionics. All right, now to talk about a strategy rule of gray matter lesions, let's just redraw here and just schematically put in here the two roots. So we had a dorsal root coming off here. We had a ventral root of the spinal nerve coming off here, and they formed the spinal nerve there. And of course, we had a little bump up here, which was the dorsal root ganglion. So just schematically remember the dorsal and ventral roots are attached to those respective parts of the cord. Now, when you talk about gray matter, what is the strategy rule here? What's the clinical rule? Notice this one is at the level, not below the level of lesion, but at the level. And that's the key point of differentiation. Now, if you think about this spinal cord and these dorsal and ventral roots, if this hand represents the dorsal and ventral parts of the roots, and this hand represents the dorsal and ventral horns of the gray matter, notice they are lined up. So the dorsal and ventral horns and the dorsal ventral roots are lined up, and the ventral roots and the ventral horn are lined up. So notice there's a direct horizontal relationship between the gray matter and the spinal nerve on that side. So keep in mind, if we just put an arrow here, there is a horizontal relationship between that gray matter and the spinal nerve system there. So when you think of a gray matter lesion, it's going to affect the motor and or sensory supply from that spinal nerve on that side at that level. So again, if this is T4, as we said, if you damage the gray matter here, or the ventral horn of T4 gray matter, you're going to affect the sensory and or motor functions of the T4 nerve. So again, notice gray matter is going to affect the spinal nerve functions at that level. And notice this one is always ipsilateral. And notice it's ipsilateral. So a gray matter lesion won't be contra over. It's always going to be ipsilateral, affecting the spinal nerve system on that side at that level. So it's two easy concepts which would help you guide yourself through picking out correct answers. So if it's a long tract lesion, the deficit is below the level of lesion. It's a vertical system, ipsi or contra. And if it's a gray matter lesion, it's a horizontal system, and that's going to affect the outflow of that spinal nerve on that side. Now, to give you a little application of that, notice a lot of times you'll see it on the exam from cord sections. And so here's a section of cord. This says it's T5. You would not have to know it's T5. You would know that it's thoracic. And I'll show you later in the notes how to differentiate segmentations. But nevertheless, this is T5. Let's say this is the left side again and the right side. So let's say that you have lesions in the white matter on the left side of the cord, whether it's dorsal, lateral, or anterior white matter. If you had a lesion on the left side of the cord of white matter, all of these tracts are going to be lost where? Below the lesion. So below T5, you would have deficit of the motor or sensory function of that tract. But notice if you damage the gray matter at T5, you're going to affect horizontally, and you're only going to affect the T5 nerve on the left side. So again, notice the rules are fairly straightforward. Those are two very critical areas of information that's going to be most important as you go through and try to localize lesions. All right. Now let's move on now and start picking up some other areas. Now you had your notes there that describe what we just said. You can read those. Here are a couple of diagrams, just a quick look at. This top one just reminds you how those nuclei are organized into lamina or layers in the gray matter. You remember Dr. Rexit is the one that did that way back in time. And you remember in the dorsal horn, notice there are 6. You don't have to identify these or spatially identify them. Notice there are 6 layers of nuclei function here. And so being dorsal horn, we know these lamina are primarily processing sensory information. And notice in the ventral horn, there are the 2 main groups of nuclei are 8 and 9. And we know these are made up of alpha and gamma. So these are motor in function. And again, the lateral horn 7 is where those preganglionic sympathetics are located. Just a brief comment. Now, here's a little more important image on this page. Now, again, notice, let's look at the ventral horn first. When you deal with the ventral horn, again, remember what's in the ventral horn here are your lower motor neurons. And again, this is alpha and gamma. Again, alpha makes up close to 2/3, 3/4 of them. Gamma, a smaller amount. Remember, both of these are referred to as lower motor neurons coming out the ventral root, just distributing through the spinal nerve system. And again, notice the alpha is to the motor end plate. That's the neuron that releases acetylcholine and all the mechanisms of muscle contraction at the motor end plate. And then the gamma, again, is that unique little outflow of motor innervation that's just innervating the muscle spindle or the skeletal muscle fibers within it. So we've mentioned that. Now let's look at the dorsal root with a little more detail. Don't get too deep into this, but you'll notice here are the dorsal root fibers coming in. These circles here, of course, represent the dorsal root ganglion. So these are your central fibers, central processes of these unipolar neurons coming into the cord that you see illustrated here. Now, you might remember within the dorsal root, these central fibers of the unipolar neurons organize themselves into a medial group and a lateral group. Just briefly note that. And notice the medial division fibers are the ones that are carrying most of the sensory modalities of all the modalities except pain and temperature. So again, notice these are general sensory fibers except pain and temperature. Now, what's unique about these incoming central fibers is that when they come into the cord, notice they do not enter the dorsal horn. Notice they bypass the dorsal horn and just form these branches, collaterals that head north up the spinal cord and form some sensory long tracts. So again, notice for touch, for vibration, again, for 2-point discrimination, and also for proprioception, the input from muscle spindles. Notice all of that is going to be bypassing the dorsal horn, and most of the fibers will form long tracts. Of course, one of the big ones is the dorsal column system, and the dorsal column system will ascend up, and of course, there form the track all the way up to the brain. A few of these fibers, not many, but a few of them will go deeply, as you see here, and they enter the ventral horn, and they're part of reflex circuitries. So again, the medial division fibers is everything but pain and temperature, and they bypass the dorsal horn. Now notice the pain and temperature fibers are the ones that make up this lateral division, and notice they're the ones that fairly close to the point of entrance, they will process and enter in various layers, lamina of the dorsal horn. And notice this is pain and temperature. So notice it's pain and temperature that will process into the dorsal horn. So remember on the exam, when you have a dorsal horn lesion, you're primarily affecting pain and temperature processing and not touch, vibration, and the others. So again, notice there's a lateral and medial division between the two different sets of sensory modalities. Now, I did mention to you early on that there are many different types of unipolar neurons. Some are classified alphabetically, some are classified numerically. Numerically, like 1A, 1B, and of those are two you might want to remember, especially 1A. This is the sensory output of muscle spindles. And that is probably one everybody wants to remember and name as a type of unipolar neuron system. So the sensory output of muscle spindles makes up the 1A. 1B is from other receptors. But notice all of the alphabet, like ones that are alphabetically named, like alpha, beta, C, those are alpha, delta. Notice those are from skin. So if they're alphabetically named, they're from receptors in skin. If they're numerically named, they're from muscle, is how that was set up. Now, you don't have to name all of those different types of unipolar neurons. Again, that's not a main theme on the exams. Of the ones from skin, you might want to remember the type C. This is the chronic pain fiber. This is the one that you take Tylenol and ibuprofen and pain suppressors for. This is the chronic pain type aching we have. All right, now let's move to the critical area of our discussion, and this is moving back to white matter. And now we're going to look back at white matter. We're going to spend the next rest of today and into tomorrow as we go through the various tracks of the spinal cord. So we want to introduce to you again this concept of long tracts. And these are the ropes that are running up and down the white matter. Now remember, if they are descending, they're motor in function. If they're ascending, they're sensory in function. We mentioned that and you remember that. And number 3 there just reminds you that these long tract systems are not just running, of course, up and down the spinal cord. They're continuing on above through brainstem and all the way, the big ones go all the way to the cortex. So they'll run the entire axis of the central nervous system. Now, here we get to a simplification that you will enjoy greatly. Now, you might remember in times past in neuro, somebody made you learn all of the long tracks, and there are up to maybe a dozen of them as you name them within different parts of the white matter. And some are going up, some are going down, some are crossing here, some decusate there. So it got to be a world of confusion. Vertigo set in as you try to follow all of those long tracks. But notice in neurology and basic diagnostic skills for cord lesions, you only really have to deal with three big ones. And so the others are there, but they do not dominate your thought processing at the moment. So you want to focus here in the notes and in your patient, these three long track systems. These are the three that everybody must know to have a good, solid background in neurology. Now, what's interesting about these three, they all operate at a conscious level. So these are easy for you to, again, test in your patient. And of these three, number one, corticospinal is the only descending motor system we'll give special attention to. We'll mention a few others, but this is our main and most important of about 6 descending motor long tracks within white matter, because this is the only descending motor system that's dedicated to your limb muscles. So again, notice this is innervation of limbs, especially distal limbs, the arm, the forearm, the hand, the thigh, the leg, the foot. And so your what muscle groups do you move most during the daytime are limbs, upper lower limbs. So that makes this one most essential. And then the other two, dorsal columns and spinal thalamic, are both ascending. So they're both sensory in functions. Now notice the dorsal column is carrying all of the sensory modalities except pain and temperature. And then notice pain and temperature is carried by spinal thalamic. So when you talk about touch, 2-point discrimination, vibration, or proprioception, that falls under the dorsal column lesion. And then spinal thalamic would cover pain and temperature. So notice again, we're only going to have to deal with 3 of these. Now, among these 3 tracks, notice there are certain principles and strategies that are very important. And these principles and strategies relative to these 3 tracks are these. And so to understand the track, you have to understand these 3 principles. First of all, when you're describing a long track all the way from cord up to the cortex, first of all, you want to know in this ascending or descending motor sensory system, how many neurons are there, the number of neurons. And you'll notice the answer is given to you. It's 3 neurons when it's sensory and 2 neurons when it's motor. So a sensory pathway will have 3, a motor pathway will have 2 neurons. So that's the first easy principle to understand. And then number 2 is knowing the 2 or 3 neuron systems. First of all, where is the location of those 2 or 3 cell bodies? That's always important to note about a neuron. If you're going to know something about a neuron, you want to know where is its cell body. That's kind of a bottom line piece of information. So you want to know the location of cell bodies along with the general topography. What's the general course of it? And number 3, clinically most important, where do they cross? Where is that deposition? Because not all, but these 3 and many of the others, somewhere in their course, ascending or descending, they'll cross the midline of the central nervous system, go to the opposite side. So they'll go from the left to the right side of the nervous system, of course, right to left. So that crossing is going to be very critical point as we move forward, because this is where you determine when a long track lesion is below IPSY or contract. That's going to be critical in that piece of information. Okay, now let's look at the 2 parts of this motor system. Now, again, as we have already just said, the descending systems are motor. So we're talking about motor pathways in these descending systems. Now, when you talk about descending motor systems, as you well know, they're divided into 2 neurons. neurons, as we just said above. There are two neurons in a descending motor system. They are named upper and lower. And so you want to have a little background information about these relative to any of these descending motor systems. Now, when you talk about, first of all, the upper motor neurons, this is the kind of a cardinal piece of information. Notice all upper motor neurons that are forming these tracts are found in one of two places. They're in the motor cortex, cerebral cortex, or in nuclei in the brainstem. Now, notice if you're in the cortex, which is the primary one that we'll talk about, notice these upper motor neurons are in that what we call the motor cortex. It's called the primary premotor cortex. You remember this is frontal lobe. Dr. Brodmann numbered these areas, area 4 and 6. Now, the Brodmann numbers are not, you don't need to make a long list of them, but a few handfuls of these are important. And we always just simply want to remember Brodmann numbers 4 and 6 are these two strips of the frontal lobe just in front of the central sulcus. So that's where a large part of these upper motor neurons generate from. Now, they also can come out of the brainstem. We'll mention a few of these in a few days later, but those are not the big ones. But the big ones we're going to be talking about come out of that motor cortex. Now, when you talk about these descending motor systems, remember when you talk about decussation in a descending motor system, it's always the upper motor neuron. So it's the upper motor neuron that will do the crossing, and you'll see that in the examples. Now notice the upper motor neurons have to descend somewhere down the system, and somewhere in the system they have to synapse with and then fire upon the lower motor neurons. Now the lower motor neurons, like upper motor neurons, have cell bodies somewhere. And like the upper, they are found in two places, the ventral horn of the spinal cord, and we know that. That's where alpha and gamma are. That's, again, our primary focal point. And then in a few days later, we will mention some of these critical cranial nerve lower motor neuron nuclei as well. And of course, there are two types of these, whether it's in the spinal nerves or the cranial nerves, they are alpha and gamma. Now, here's just a little schematic of what this type of descending motor system looks like. So it's an upper and a lower motor neuron involved. Notice the upper motor neuron here, the circle represents the cell body. That's the upper motor neuron cell body. Where are they located? Either in the cortex or brainstem, motor nuclei. And these are the fibers that descend down, and somewhere, just showing schematically here, this is where they cross. So that, notice we started here on the right side, and then we crossed to the left side of the nervous system. So there's a crossover point. And then when they cross, they continue their descent. And so this continues on down its course. And what's going to happen somewhere in the system, it has to locate and synapse with the lower motor neurons. Now notice the lower motor neurons, here's the circle for its cell body, is going to be somewhere in the central nervous system. But notice this, the lower motor neuron that leaves the central, its axon leaves the central and becomes a peripheral nerve. So all of the upper motor neurons are exclusively in the central system. But the lower motor neurons begin central, but as the axons proceed, they don't end up in a spinal or cranial nerve. And it's the peripheral nervous system that distributes these out to the motor end plate and to skeletal muscle. So again, it's an upper descending to a lower. So the lower, you remember, is going to be a horizontal relationship to the spinal nerve on that side. So remember, if it's a lower motor neuron lesion, it's always ipsilateral, as we said, because these fibers are coming out of the gray matter of the cord. So that's coming out the ventral root, the spinal nerve. So this is an ipsilateral lesion, and it's always going to be at the level. Remember, the rule for a lower motor neuron is that ipsilateral at the level. But if it's an upper motor neuron lesion anywhere along the way, this is the long tract, so the lesion is below, and again, it's going to be below, and it's going to be below ipsi or contra, again, depending on which long tract. So that's the two classic rules. Noticed a question about bipolar neurons. We have not mentioned those yet. What the neurons that we mention are mostly unipolar, such as in the dorsal root, or of course, the majority of neurons are what are referred to as multipolar. Bipolar neurons are very few in the nervous system. Bipolar neurons are only found in three of the major sensory systems, which is olfactory, optic, and the eighth cranial nerve with balance equilibrium. So bipolar neurons are very few of those and only restricted to certain special sensory pathways. So we have not mentioned those. And uh, probably other than a few casual mentions when we talk about the brainstem, we'll not talk too much in details about them. Okay? All right, now notice that as we are beginning to now leave the general overview of long tracts and upper and lower motor neurons, here's just a short list of some of the major descending motor pathways that are found in different parts of the white matter, whether it's dorsal, lateral, or anterior. And these, some of the names you might remember: rubospinal, vestibulospinal, reticulospinal. So those are names of some of the others, but again, the main one that we're going to be dealing with is corticospinal. And why? Again, that's the only descending motor system that moves your distal limbs. And of course, the corticospinal tract into the forearm and the hands and all the magic movement that your hands can provide are going to, of course, be part of this system. And the others are dealing with either reflex innervation of skeletal muscle or with trunk innervation, because we have a different motor system for our trunk musculature as well. So again, corticospinal is our main one. Now notice all of these descending motor systems are double named, corticospinal. And pay attention to that. The first word and the second part of the word tells you some information. Cortico tells you where the upper motor neuron cell bodies are. So a cortico is one that comes out of the frontal lobe motor cortex. Like rubospinal, that's an upper motor neuron that comes out of the red nucleus there in the brainstem and so forth. And then the second word, spinal, in this case, is going to be where the lower motor neurons are located. And we know in the spinal cord, that's the ventral horn. So let's look at our first of these three major long tracts. This is descending system, corticospinal. And again, notice the corticospinal, again, is the really big one everyone must know, because this is providing that volitional, voluntary movement, skillful, exquisite movements of the limb muscles, especially the distal limb muscles. Now, when you kind of put that system into an image, here in this first image, and each of these long tracks will have two images. The first one's kind of a simple wiring diagram, and the second one will be a little more real-time diagram. But here in this simple wiring diagram, you'll notice that this is corticospinal, so it's obvious the upper motor neurons are going to begin here in the frontal lobe. This is where the majority, not all, but majority are. So this circle here represents that origin of that upper motor neuron there in the area 4, area 6 of the frontal lobe. And that's, referred to as precentral gyrus. So in this example, we're starting here on the right side of the brain. So we got a fiber beginning to descend. Now notice the axons of these upper motor neurons then are going to descend out of the cortex. And notice the next main part of their pathway, they squeeze through this little narrow strip of white matter here that's called the internal capsule. You remember that's a critical part of neurology. And you remember the internal capsule is kind of the doorway to the cortex. So not all, but most of the major motor systems coming out of the cortex or sensory systems coming into the cortex have to go through this portal, this doorway. And the internal capsule is this main portal entrance to and from the cortex. And it's going to be divided into limbs. And you remember the posterior limb is important here. This is the area that's mostly involved in stroke. So capsular strokes, which are the most common site of upper motor neuron damage, occurs here with this posterior limb. Then after leaving and coming, squeezing through that posterior limb, notice it's going to continue its course now into and down the brainstem. Now notice we're still on the right side of the brainstem, and then we're going to continue all the way down the brainstem, and then we're going to come to the point of decussation, crossover. And notice for this pathway, it's said to be in the lowest level of the brainstem, caudal medulla, or right at the junction of medullary and spinal cord, any way you want to phrase it. But caudal medullary, the lowest level of the brainstem before it junctions with cord, is where the crossover is. Now, you probably remember a little detail. Not all of the fibers cross over, but close to 90% do. And the others stay uncrossed, but eventually they will cross in the cord. Now, this descending corticospinal system is made up of approximately 1 million axons. So there are 1 million fibers squeezing through that capsule and down through the brainstem. And roughly 90% of them will cross over here to the, again, now we're crossing over here to the left side. Now notice they continue now down the left side of the spinal cord. And in that descent, they're going to then, as illustrated by this blowout here, within each of the 31 segments, notice some of these fibers peel off here as it shows there into the ventral horn, and they fire on the lower motor neurons. So notice the upper motor neuron is continuous from the cortex uninterrupted down to where at each of the 31 levels, some of the fibers peel off and synapse within the ventral horn. Now, don't make a very common mistake where you miss a lot of questions. For some reason, we like to think that once this upper motor neuron has decussated here in the lower medulla, that when you continue now in the spinal cord, you want to call that a lower motor neuron, and that is no. So notice this descending fiber in the cord is as much upper motor neuron. So this is as much upper motor neuron as the fibers here in the brainstem and the cortex. The only difference is one set of fibers are above the decussation and one set is below the decussation. So keep in mind, that's going to give you a clue now as to how to determine long tract lesions are where? Below ipsi or contra. So if the lesion is above decussation, let's just say, for example, here, let's say the lesion here is somewhere above in this descending system. Above decussation could be a capsular stroke, could be a cortical lesion, anywhere. If it's above decussation and you damage it here on the right side, so where is the deficit? It's below and affecting the left muscles. So again, notice the rule, of course, is if the lesion is above decussation, your long tract lesion is below and contralateral side. So the lesion is on the right side of the nervous system, but the deficit is shown over here in the left limbs. So above decussation, it's below and contralateral. So this is going to be your below contralateral type lesion. But if you damage the upper motor neuron in the spinal cord, that would be below decussation. So now notice the fibers are on the same side as the moving muscle. So this one is going to be below. So if you damage the left side of the spinal cord, you're going to affect the left limbs. This is below IPSY. So it's an easy rule. And because of that, you should never, ever, never, ever miss a long tract lesion. All you got to know, are you above or below decussation? Then there is your bottom line. You're either above, you're below contra, below decussation, you're below IPSY. Now notice in the white matter, the corticospinal tract sits over here and in that lateral aspect of the white matter, of that lateral funiculus, and that lateral kind of a dorsal position. So that's where the corticospinal tract is located. And what is corticospinal tract? Don't forget, it is upper motor neuron. So remember, the corticospinal tract lesion is an upper motor neuron lesion of these fibers descending. And then you synapse in the ventral horn with the lower motor neuron. Now, we already know the lower motor neuron, and this is alpha and gamma. So this upper motor neuron fires both sets of lower motor neurons, alpha and gamma, but there's a co-activation there. But our focal point right now is to the alpha one. So you fire on the alpha, and this comes out the ventral root, the spinal nerve, and goes over here at the motor end plate at the skeletal muscle and results in the band sliding and contraction. So again, the lower motor neuron is the one that's leaving the gray matter. So remember, lower motor neurons are in a horizontal concept. So if you damage the lower motor neuron, either in the ventral horn or anywhere along the way, let's say this is T12, let's say that's the T12 cord segments. If you damage the ventral horn here on the left side at T12, or you damage the T12 ventral root or the T12 nerve, you're going to affect what? This is always at the level. And of course, it would be always ipsilateral. So don't forget those three classic rules that will save yourself on the exam. So if you get in the middle of a question, you think you've just got totally confused, totally lost, stop, go back to the beginning and remember the three classic rules. If it's a lower motor neuron lesion, it's ipsilateral at the level. If it's going to be a descending system, it's below IPSY or contra, and again, depending on whether you're above or below decussation. So always go back to that kind of basic position there. Now, those three principles are printed out here for you, so you can certainly read this. It just reiterates what we said, and it's just very critical to keep that in mind. So make sure you pay attention to these three clinical applications so that you can make this a patient-oriented concept and not just a set of words. All right, now let's look at this in a second type diagram where we're looking at a little more real-time image of the nervous system. And you'll notice here, the top of the figure, we have, of course, the cortex. That's obvious. Then we've got brainstem here, midbrain, pons, lower medulla, some representative cross sections there. And then below the brainstem, we don't have to draw in 31 sections of the cord, just representative ones. Here's upper spinal cord, lumbosacral, lower spinal cord segments. So again, we can just place this pathway back into that kind of configuration. Now remember up here on the motor cortex, we would cover this in other parts of the notes. You remember you have the weird looking abstract guy, the homunculus, laying over the cortex to give us some representative of what part of the motor cortex is dedicated to what part of the body. So you remember the head region, put a little smiley face there. So remember, the head part of this motor cortex is in this lower lateral cortex, just above the horizontal fissure there. Remember, the large middle part of this cortex is dedicated to the upper limb. You don't recognize that. That's a forearm and a hand. So the upper limb is dedicated here laterally, so is the head region. But remember, the lower limb here, notice the lower limb is medial. So keep in mind, if you think in lower limb versus upper limb, you're going to think medial versus lateral motor cortex. So notice these upper motor neurons dedicated to the lower limb have their origins over here on the medial part of motor cortex. And of course, the upper motor neurons of the upper limb are there in the lateral cortex. But notice both of those converge together as you go through the posterior limb of the internal capsule, that little narrow strip of white matter in the subcortical position. Now notice, just for the sake of description, notice we're starting this one on the left side. So we're coming down the left side now, coming this vertically down. So we come down the left side of the brainstem still, and then where do we cross? Lower caudal medulla. So there's the decussation. So again, notice that crossing over of roughly 90% or so of these million fibers forms that large, massive crossover point called the pyramidal decussation. It's in the lower medulla. Notice it's on the ventral side. So keep in mind, this is dorsal, this is ventral side of the brainstem. So notice this crossover of the motor system is on the ventral side of that lower medulla, making this massive pyramidal decussation. And then after crossing, notice now we're descending now on the opposite side of the nervous system. Now we're on the right side of the spinal cord. So here's where that corticospinal tract sits there. You see it indicated. So what is the corticospinal tract? Don't forget, this is upper motor neurons. Don't try to make it a lower motor neurons just because it's in the cord, a common big mistake. Now notice in the ventral horn, we have the cell bodies of the lower motor neurons, alpha and gamma, but alpha shown. And so the alpha is the lower motor neuron system here in the ventral horn. And these flow out through the spinal nerve system out to that particular spinal nerve at that level to innervate the skeletal muscle supplied by that spinal nerve. So again, with that having been said and what we've already known, the big story here is where's the decussation. So remember, all lesions above decussations are what? Below contralateral. So all lesions above. So if you had a corticospinal tract lesion in the cortex, a capsular stroke on the left side of the brainstem, all the way down to lower medulla, if you had a lesion anywhere along here, your deficit is below. We know that always below and the opposite side of the body, contralateral. But notice if you are damaging corticospinal fibers, upper motor neurons in the brainstem, in the spinal cord, now you're below decussation. So note, just make an obvious note, in the spinal cord, beginning at C1 all the way down to the end of the spinal cord, all of those upper motor neurons are below decussation. So if you have a spinal cord lesion of upper motor neurons, what is your lesion? It's going to be ipsilateral and below. So again, notice what's the difference between a brainstem lesion and a spinal cord lesion of corticospinal tract? Brainstem is below contra, cord lesion is below ipsilateral. That's the difference. And then they peel off again at each of the levels. Of course, these tracks keep going on down. Obviously, they continue their downward course, upper motor neurons, but at each level, they peel off and fire onto the lower motor neurons. And when you damage a lower motor neuron, what is it? At the level and ipsilateral. Now, if you put that into a diagram, like the next one, if you put that here back into a little schematic. So remember, in the spinal cord, we have two motor systems. One upper motor neuron, the cortical spinal tract, and one a lower motor neuron, ventral horn. So again, what's the difference? Cortical spinal tract is below ipsi in the cord, but notice the lower motor neuron is at the level in ipsi. Now notice they are both ipsilateral in the cord. So don't let that slip by you. So if you have an upper motor neuron or a lower motor neuron lesion in the cord, they're both ipsilateral, but one's below the lesion, one's at the level. So we have said that many times. And if you want to read that again, it's in that little 1, 2, 3 discussion above. Very critical to review that. That's the core piece of information to dealing with motor lesions of these two types of fibers. Okay, so notice that is what we refer to as volitional. That's the cortical willful move. I want to move this elbow. So now notice that movement there is driven from the cortex. That's corticospinal lower motor neuron. So again, we want to now go and look at the flip side of that other mechanism. You remember, you can also contract this biceps muscle. You can hit my biceps tendon and get a reflex jerk. That's a different system than this cortical driven, because this reflex mechanism is core generated, it's not going to be related to the actual cortical drive. Now, when we deal with reflex, that's where we're going next. That's where we'll end up for the day. When you deal with reflex mechanisms of innervations, remember we said early on that when you contract the skeletal muscles, it's under two mechanisms. You can do it willfully or reflectively. Now, we've already covered the volitional side of it. Now, let's look at reflex. Now, when you deal with reflex innervations, notice there are two cardinal rules to go by. Now, first of all, notice that these are involuntary. So when you hit my biceps tendon and that muscle jerks, I had no volitional control over that. That was a reflex response. So the first thing to remember is that they are involuntary. And the second thing to remember, there's always two neurons at minimum in a circuit for reflex. There always has to be a sensory and a motor neuron. So you have to have a sensory and a motor neuron. A space there is needed. So there's always a sensory side and a motor side to a reflex. Now, you probably remember there are half a dozen types of reflexes. But in terms of clinical neurology, the reflex system that you need to have some information about is this classic one, the deep tendon, or sometimes referred to as the stretch reflex. This is the simplest of all the others. So, and it's the one you need to understand. Now, being simplest, what I mean there, this is the only reflex system that's basically a two neuron system. It has one sensory and one motor neuron. So again, it's going to have two neuron sequence, one sensory and one motor. So the deep tendon is the critical one. Now, what's important about this reflex, I think neurology, and you understand this, testing this reflex, as it says there in number 1, and testing the integrity of it and see what kind of response you get is a very critical piece of information to allow you to discern between a motor weakness being a lower motor neuron problem or an upper motor neuron problem. So it's going to be a very important clinical tool for you to discern between an upper or a lower lesion. So it's a very valuable. Now, this circuitry, of course, is there for you to do that. That's a very important part of the testing of it. But notice number two, equally and maybe more important, is this circuitry runs 24/7. So this is running 24/7 in all your cord segmentations and your spinal nerve systems. And this segmentation is running simply to maintain enough tone in your muscle systems to defeat gravity. So this is how we regulate muscle tone, is via this. One of the major ways is via this circuitry, this deep tendon reflex circuitry. So right now, you remember within all of your skeletal motor systems, trunk and limbs, notice you have these motor units, that is the number of muscle fibers innervated by a muscle fiber. Right now, you have so many motor units going in and out of tone. Of course, you're not aware of it, you're not conscious of it. But as you're sitting somewhere or standing, you know, you have to make sure you keep enough muscle tone that gravity doesn't take us over, because gravity is always trying to take you down. And whether you're sitting, standing at different levels of positions, you always have to maintain enough muscle tone within all the skeletal muscle systems to defeat gravity. And this system is firing continually. So right now you got motor units going in tone, motor units are pulled out of tone, and you're regulating the tone generated by these motor units to keep you vertical. So if I fall backward, I got to pull myself forward. If I fall forward, I've got to again contract muscle tone and contract that and correct that fall. So again, not only is it a useful tool for you or the patient sitting in front of you to do a simple reflex testing to see what kind of response you have to help you determine upper versus lower, but it's also this very important physiological role of regulating muscle tone. Now, the thing about the reflexes is, again, this is the deep tendon reflex. This is the simplest. And here's the circuit for it. Again, it's one neuron sensory, one neuron motor. Now, notice the sensory side of this type of reflex generates out of these muscle spindles. Now, here's just an illustrated a little spiral there, just to illustrate a muscle spindle in a muscle fiber. Now, remember, muscle spindles vary greatly in their concentration. They are between the muscle fibers. They are in parallel with the muscle fibers. So what the muscle spindle responds to is stretching the muscle. So if you take a muscle, biceps, origin, insertion, and you stretch it, now you're stretching the muscle fibers, you're also stretching the muscle spindles. And the stretching of a muscle spindle generates a sensory output. And this sensory output, this red line, should go into the muscle spindle, not up there. But nevertheless, the generation of the sensory output of the muscle spindle here is the 1A. And this is the one I mentioned to you earlier. When you're identifying different types of unipolar neurons, you don't have to classify all of them, but certainly you want to classify 1A fibers. That's one of the key ones to remember the name of. Why? The 1A output of a muscle spindle is providing the sensory side of this input for the reflex circuitry. Now notice the unipolar neuron has its cell body here in the dorsal root ganglion, and the central process is moving into the dorsal side of the spinal cord. And notice this is the type of central process that is going to go directly into the ventral horn, and there's only one synapse here, and that's in the ventral horn between this 1A fiber and the alpha. And so here is your alpha. This is your motor side of this reflex. So the alpha is the motor side, and the 1A is the sensory side of this afferent side of this reflex. So again, I go to your office. Doc, I don't know what's wrong, but I can't move my right arm anymore like I used to. It seems to be weak. Now remember, weakness of muscle is not specific for upper or lower. You're going to get weak muscles with either event. So as you're listening to me there, I don't seem to have the strength I thought I used to have. The first thing you're going to do is pull your mallet out and test my reflexes. You're going to hit the biceps, the triceps, the wrist reflexes, see what type of jerk you get. And a normal reflex, you hit the biceps tendon, you get a single jerk. It's a one-time single jerk is the normal response. So you're going to be testing me for the integrity of that reflex. So again, notice what happens when you hit the biceps tendon with the mallet. What do? You abruptly and acutely jerk the muscle. So when you jerk the muscle, you stretch it, all the 1A fibers fire out of the biceps via the dorsal root directly to the ventral horn, and synapses there with the alpha, and then the alpha back to the motor end plate is going to be responsible for that jerk, that single jerk. So again, notice the alpha is the lower motor neuron system common to both volitional movement of muscles and reflex, because it's going to be common between both mechanisms. So again, that's the basic, I guess you could say, the basic circuitry for that. Now remember, that's running 24/7. There's a little discussion of that. Now here's another example of a deep tendon stretch reflex. Probably the most common one you do, of course, is with the patellar reflex. Now the patellar reflex here, you take the mallet and hit the tendon here. This is the insertion tendon of the quadriceps. So when you hit the quadriceps tendon, you stretch the quadriceps, you fire all the 1A fibers coming out. These are 1A afferents. They fire into, and notice they go directly and synapse directly onto the alpha, which is in red. This is the lower motor neuron back to the same muscle at the motor end plate, and you get the knee jerk. So you get that classic response. Now, this diagram also reminds you of another important part of this circuitry. In order to get this knee jerk, at the same time, you've got to relax the antagonist muscles, which in the thigh are your hamstrings, posterior thigh muscles. So notice this 1A fiber coming into the gray matter has some collaterals that go through some interneurons that are inhibitory in function. And it's these collaterals, inhibitory neurons, that via this purple is going to shut down the hamstrings. So you've got to relax the hamstrings at the same time you're contracting the quadriceps. And notice this type of circuitry is called reciprocal inhibition, is the name given to that. So, and like in the biceps, as soon as you hit the biceps tendon, 1A into the ventral horn, but at the same time, you're firing inhibitory neurons to the triceps so that it's relaxed so you can get this biceps jerk. So you've got to shut down the antagonist muscles. Now, here are some of the typical reflex cord segmentations that you're doing. You're familiar with these. You remember the knee reflex. So if you look at this one up here, you know, since this is patella, this cord segment represented here is L4. So the L4 is the primary cord segment where the patella reflex is, where this circuit is located. So patella, the ankle, the Achilles reflex, you got the same thing there. Remember, that's an S1 via the tibial nerve of the lumbosacral plexus. And the biceps are 5, 6, musculocutaneous. Triceps are 7 and 8. And of course, there is a cremasteric reflex. Now, let me mention this one real briefly. Not only do you have deep tendon reflexes like the ones we're talking about, but also remember they are cutaneous reflexes. So you can stroke your abdominal skin very lightly and the abdominal muscles will reflectively contract. You get an abdominal contraction. You know, in the male, you can touch the inside of the thigh, and by a reflex circuitry, you can elevate the testis via the cremasteric reflex. And notice that's through the genital femoral branch of the L1 nerve there. Another one, there's an anal reflex. There are other reflexes that you would refer to as cutaneous reflexes. But these are just some, not all of them, just some of those. All right, now let's come to this most important page here for the reflex system. Now, this reflex system, what is the mechanism of spastic and flaccid? Let me go back, if you'll bear with me a minute. I forgot to mention the words. You know them, but let's go back to this cord section here. Now, remember, we said when you damage upper motor neurons, again, they're going to be upper motor neurons are going to be below and ipsilateral in the cord. Lower motor neurons are at the level and ipsilateral. But notice two key words here have occurred. Notice the words spasticity and flaccid. You remember, these are two constellations of events that describes a response of a muscle to an upper versus a lower motor neuron lesion. So notice if you damage the upper motor neurons here in the cord, the corticospinal tract, below and ipsilateral, the muscles will be spastic. They will present as a spastic characteristic. But if you damage the lower motor neuron, say in the ventral horn, the muscles there will be flaccid. So we've got two terms here, spastic versus flaccid. So when I came into your office and mentioned I've got a weakness here in this right arm, and you thinking internally upper versus lower progressive lesion, then you're going to take your mallet and see what kind of response. So if you hit the biceps tendon, instead of a jerk, single jerk, you get a chronic contraction here, spasticity, that would indicate I'm developing upper motor neuron. Or if you hit the biceps tendon and there's a minimal jerk, very little jerk here, minimal or none, so reduced reflexes is going to indicate, again, your flaccid condition, and that is lower. So back to where we were with those two terms in mind, that's what we're getting ready to describe, is why you're going to get spastic versus flaccid. So let's jump over a few more pages. Now, very important figure here, because this gives us the basis of why an upper motor neuron is going to result in spasticity and why a lower motor neuron will present flaccid signs. So let's look at, again, you recognize the diagram. We've seen this before. Down here at the spinal cord segment, here again is that deep tendon reflex circuitry. So you've got muscle spindles here in the skeletal muscle generating 1A fibers directed to the ventral horn, the lower motor neuron alpha back to the same muscle motor end plate. So now you've got that sensory motor circuit. Now notice again, this is running 24/7. And again, main physiology here is maintaining enough muscle tone in these motor units to keep us vertical. Now, I think it's kind of obvious to you physiologically, if this circuit is running more rapidly, running much more rapidly, rapid speed, that's going to result in increased tone. And if the circuitry slows down here in these two neuron loops, you're going to reduce tone. So what's actually going on within your body, these circuits are the speed of the firing is being regulated, fast or slow. So if you need to have muscle tone increased here and less tone there, you're going to be changing the speed of firing within this loop. Now, what is controlling the speed here is not in the cord. What is controlling is up here in the higher brain center. Cerebellum is one major area, and there are some areas in the brainstem. So there are higher brain centers, cerebellum being a major one, that has its role and part of its role in maintaining muscle tone. But the cerebellum sits up here at the posterior cranial fossa. These circuits are down here in segmental levels of the cord. So how does the cerebellum going to talk to the segmentation? Not directly. Cerebellum never talks directly to lower motor neurons. It can only relate to lower motor neuron function via the upper motor neuron system. So here is your critical piece of physiology for spastic versus flaccid, is this statement in red. So these upper higher brain levels, cerebellum, what they're sending down through the upper motor neuron systems, this what is referred to as net inhibition. And net inhibition is critical here because the net inhibition from the cerebellum and other areas is going to be via the upper motor neuron system. It's going to put the brakes on this circuitry. So remember the upper motor neurons here. Notice here the lower motor neuron, this alpha, can be generated either by cortical spinal firing. Of course, it's generated also by 1A firing. And so what is regulating the speed of this firing here between alpha, gamma, upper, and the 1A fibers, what is regulating that speed of firing is this net inhibition coming from higher brain centers. And the upper motor neuron is just a highway that the net inhibition is brought down to this segment. So again, if there's determination you need a increase or less tone, you're going to increase or decrease the speed of firing. So again, notice this is what's coming down through the upper motor neurons, cortical spinal, reticulospinal, all of them do this. And actually cortical spinal is not the main one. Reticulospinal is really the main damage that's going to affect this net inhibition, but they all do it. But nevertheless, there's net inhibition to brakes. So what happens when you have an upper motor neuron lesion, whether it's above decussation, whether it's below decussation, what are you going to have? Lose the brakes. So once this thing starts firing here, once your loop starts firing, there are no brakes to slow it down. So it runs uncontrollably. And so now taking the brakes off, the upper motor neuron lesion, taking the brakes off, you hit the biceps tendon, instead of a single jerk, you get this chronic contraction. So spasticity is a marker of an upper motor neuron. You lose the brakes. So what you're going to have is increased activity of the reflexes, which is referred to as spasticity. So again, whether it's above the lesion, this would be below and contralateral spastic muscles. If it's a cord lesion, it's going to be below and ipsilateral spastic muscles. But notice if you have a lower motor neuron lesion here, if you knock out the alpha, I don't care what you do with the central pathways or the 1A or the cortical spinal, if you don't have an alpha, you can hit my biceps tendon all day long and you're going to get a very minimal or no response. So notice that is what's referred to as flaccid. These are decreased activity of the stretch reflexes. So again, the upper motor neuron is providing that brakes to the ventral horn area. And without the upper motor neurons, there are no more brakes. So the circuitry can go rapidly firing spastic. And if you have a lower motor neuron lesion, notice that's going to end up with a decrease of reflex activity, and that's going to be your flaccid. So again, notice these two terms are very important, spastic versus flaccid. Now there are in the notes one other type of reflex system. This is just the opposite of the deep tendon. This is one of the several others. And let's just mention this one because it has importance within our motor systems. This is called the inverse reflex. Now, notice this one generated from a sensory receptor in muscle again. but these are called Golgi tendon organs. And notice they're embedded here in the tendon of the muscle, not within the muscle fibers like muscle spindles, but in the tendon. And these Golgi tendon organs, what they're monitoring is how much tension is put on the muscle. Now, notice again, uh, when the Golgi tendon organs generate a sensory output, this is the 1B type fiber, and similar to the 1A, but certainly different in one major way. Notice when this one comes into the dorsal root, notice here there's always interneurons. Notice there are always interneurons between the 1B and the alpha. And the 1B, these interneurons here are going to be inhibitory. So what the 1B fiber does, instead of excite the alpha, it shuts down the lower motor neuron system. And this is protective to the muscle so that you don't overlift something and damage the muscle. You could tear the muscle, stretch the tendon out off the bone, or tear the muscle itself. You'll see this in weightlifters. They'd be in the gym lifting this barbell, more weight than they should be lifting, but they want to impress somebody. So they're lifting this barbell and they are straining very mightily, trying to get this barbell up. And so they're putting a lot of tension on these limb muscles. And you're going to reach a point where the Golgi tendon says, okay, smart boy, you've reached your limit. If you continued, you're going to tear the muscle. So when the Golgi tendons reach their threshold, they fire. And what do? Via the 1B, they shut down the lower motor neurons, and the weightlifter looks like he drops the weights, but he really didn't have anything to do with it. Cortically, notice the weights dropped, crashed to the floor because all lower motor neurons were shut down. So the inverse reflex is protective there for the actual muscle itself. And then a summary of all of this. This is the critical mass for exam purposes. What does this patient look like? So if I walked in your office with either an upper or lower to one of my limbs and you were testing and went through reflex testing and so forth, what are some of the classic presentation of this patient with these different lesions? Now remember, notice lower motor neuron lesions. We know the rule. What's the rule for lower motor neuron lesions? They're at the level and ipsilateral. We know that. And again, don't forget that. That's the simplicity side of all of this noise. And then if it's an upper motor neuron lesion, we know the rule there. This is descending long tract. These are below the lesion, contra or ipsi, and what determines that? Above or below decussation. Now notice, let's look at the lower motor neuron first. Now notice here, when you deal with weakness, it's there. So weakness is not a feature you can look at clinically. Now notice over time, the muscle mass will significantly atrophy. So if I remove the musculocutaneous nerve from this biceps muscle, it is said this biceps muscle has lost its lower motor neuron, and it's said to be a dying muscle. And so over time, there's a decrease in volume of the muscle cells. So there's significant atrophy. So when I come into your office with an acute lesion, muscle mass is okay. But I come back a month later, you can notice whatever mass the biceps had is beginning to decrease. So again, notice there is significant decrease of size of muscle over time. And fasciculations is another classic marker of upper or lower motor neuron lesions. Fasciculations are not easy to explain, no really basis for them, but these are those intermittent and transient vibrations of the muscle itself. They just start quivering. So the patient can feel it. You can see it as an observer. So the biceps would just go through a few seconds of quivering, these transient vibrations of the muscle, and then they slow down, then they'll come back. And notice fasciculations are more prominent in the early weeks following a lower motor neuron lesion, and over time they begin to dissipate. So that's a very another classic marker. So anytime you see severe atrophy fasciculations, you know the exam is describing a patient with a lower motor neuron event. Now, of course, the two big ones are these. So you've got reflexes and the tone within the muscular system. So again, notice if you have an upper motor neuron lesion, you're going to have spasticity. It's increased. So you have, instead of a single jerk, you're going to get all of the contractions involved there, multiple contractions. And if it's a lower motor neuron, you get a areflexia or maybe hyporeflexia. You get a very reduced amount of reflexes. So again, notice increased versus decreased or absent. And then in spasticity, the tone is greatly increased here with an upper motor, and it's greatly decreased with lower motor neuron. So again, you get a tremendous difference in tone. And then you get these two are alterations of some of the reflexes. And these are alterations of cutaneous reflexes. Now, I didn't mention a while ago, you remember another classic cutaneous reflex is stroking the sole of the foot. And if you stroke the sole of the foot of a normally wired person, the toes will flex. But if you have an upper motor neuron, cortical spinal tract lesion for that lower limb, you stroke the sole of the foot, and again, notice instead of flexion, they extend, and the big toe extends dramatically upward. So sometimes it's called the extensor reflex as well as Babinski. So Babinski extensor reflex are the same thing. So you get that extensor reflex with an upper motor neuron lesion. Now keep in mind, you can't test Babinski on a newborn because you remember from birth up to 18 to 24 months, it takes 18 to 24 months, up to 2 years to kind of finish the major myelinization of corticospinal tract. So up until 18 or 24 months, you take a baby infant, stroke the sole of the foot, they all are going to show extensor reflex, but that's normal. It's only in the older than a 2-year-old and into adulthood is this a positive reflex. And then the class 9 spasticity is another alteration of reflexes. And this is dealing with that inverse reflex that we just talked about. So remember, the inverse reflex is with the Golgi tendons. So when they reach their threshold, what's going to happen? They're going to fire and shut down the lower motor neuron system. So the class knife is another test with a spastic individual. Again, you remember the most common type of lesion, upper motor neuron lesion, is going to be a capsular stroke, internal capsule, posterior limb. And when that person results from a stroke, you notice what is going to primarily, you remember, spasticity is primarily going to be illustrated in the upper limb in the flexor muscles and in the lower limb in the extensor muscles. That's where the spasticity is going to be more commonly demonstrated. And so take this upper limb, you got this individual, flexed elbow, flexed wrist, flexed digits. They're very tight. Tone is greatly increased there. It's hard to unbend those fingers or bend this elbow. But what happens, you can put just a minimal amount of tension on that forearm. And what happens, the threshold level of the Golgi tendons has decreased. And so now you can fire the Golgi tendons very easily. They fire and the lower motor neurons are shut down, so the spasticity relaxes. You turn it loose, it goes back to spastic. Pull on it again, you fire the Golgi tendons, that releases the lower motor neurons, and you can collapse the spasticity and comes back. And it looks like To the early neurologists that describe that, it looks like taking a knife blade, pulling it out of the handle and pushing it back in. And that's where the term clasp knife spasticity. So the type of spasticity you see in an upper motor neuron is called the clasp knife type. And it's going to be compared to other types like in basal ganglia disorders. So again, make sure you pay attention to these presenting pieces of information from a patient with these two motor lesions, upper versus lower. One other thing about cord lesions particular, you remember there's this event called spinal shock. So when there's trauma to the cord, compression, some major trauma to the cord, notice for a week, maybe a week and a half, there's a timeline, what's called spinal shock to the cord. And during that time, you can't test for upper versus lower because during spinal shock, that's the time of inflammation, edema, swelling, all of that is acutely going on. And it will take a week to maybe 2 weeks for that to subside. And only then can you get a true picture of upper versus lower. Because during spinal shock, all of your testing is going to come up flaccid. And again, that's not a true test until all of that inflammatory response is over. And then you can do your testing for upper versus lower.